We can get started with this one. More people coming in. All right, so chest trauma is a great section, and there's not much on like the paramedic side compared to the EMT side that's really different for us. So this is going to be a good topic review, kind of regardless of what level you're at. But in this one, we're going to talk through some good test taking strategies and tips and certain kind of differential diagnoses and special little words that can clue you into one particular disorder compared to another disorder or another injury pattern. All right, so much of all of this stuff just becomes pattern recognition. And the better we get at just recognizing, hey, this is the pattern of symptoms that's at least common, or at least it's the classical presentation of a particular injury, then that's going to serve you better as you build that foundation and start to look at, you know, testing for national registry or class exams or whatever it might be, right? You have to start with, when is it kind of normal for how it looks, right? So when we talk about pneumothorax, what's normal about that presentation before you start getting into kind of weird or kind of on the fence presentations with it, is starting right away with what's the kind of, you know, stereotypical classic presentation of it. And then later on, we can move to kind of abnormal presentations of things. But the nice part with trauma is it's usually comparatively more straightforward than the medical emergencies. Okay? And remember, when we're looking at kind of national registry style stuff, the medical patient, you know, more kind of pertinent information for us in a medical patient is in the history. Right? The physical has its role, but the history really matters more. On the trauma patient, the physical exam matters a bit more. It gets more of our focus than, you know, their past medical history does. Right, so trauma, we emphasize that physical exams. We're going to spend a lot more time talking about the physical signs and symptoms and that presentation that's going to show up. All right, so let's jump right into it. All right, little anatomy review. I'm going to have kind of a 3-slide segment of a few different kind of layers of the thoracic cavity, right? Because that's what we're going to be talking about. We're talking about the thoracic cavity. Right? So it's chest trauma, so thoracic cavity and the pleural spaces. Right? We're going to get to that when we kind of peel off another layer. Right? But looking at it from the kind of skeletal system side, we start to see, you know, the things that we're going to be talking about. Right? So primarily, you know, we're looking at the ribs. We have the sternum. And we have the sternum. The bottom piece there is our xiphoid process. Xiphoid process. And collectively, all three of these are called the sternum, but it's the xiphoid process is the little triangle tip at the bottom, the sternum or the sternal body. And then that top part is the manubrium, right? Manubrium. Now, one that some books will really talk about, it's a good kind of Jeopardy style question, is right there where the manubrium comes into contact, or where it meets up with the sternal body, is a little notch. And it's called, not the AG, right? It's called the angle of Louis, right? Angle of Louis. And it's a good anatomical marker because it's where the second rib comes into contact with the sternum, right? We can see the first rib up here, right? That first rib up there kind of gets masked by our clavicles a little bit. So it's really kind of difficult. You can't really palpate that first rib, right? It's not really there. I mean, that's pertinent when we come talking about, you know, needle decompression or anything like that, where we have to find our intercostal spaces and be able to figure out which intercostal space are we actually feeling. So keeping in mind that clavicle really masks the first rib, right? Then when we drop down, right, that angle of Louis, that notch there is where the second rib comes into play. And so if you put one finger in that kind of sternal notch that's right there on top of the manubrium, there's a little kind of divot there that you can rest your finger right in. And if you make your thumb and your middle finger as a little triangle with that, right, and then kind of really palpate in that first space that you can rest your thumb and your middle finger into is this first intercostal space, right, between that first rib and the second rib, because we can't really feel the first rib. So it's one way to go right away and say, okay, there's my first intercostal space, there's my second intercostal space, and then we can palpate out from there. And so angle of Louis there at the base of the manubrium, top of the sternal body, is where those kind of come into contact with us. And so that's the kind of quick skeletal review. Remember, we've got, what is it, 12 pairs of ribs. The top 10 all connect back up to the sternum. And then we have the floating ribs are the last two pairs at the bottom that don't, you can see right down there, they don't connect up with the cartilage going back up to the rib cage, or back up to the sternum, right? Kind of fusing up into the rib cage. All right, another component, once we kind of peel back the layers of the skeletal system, right, then we get into the mediastinum, where we're going to spend a little bit of time talking today. And mediastinum is really, this space right here, right? It's the space in between the lungs, right? Media is middle, stinum is referencing sternum, so it's right behind the sternum, right? And it's right in the middle between the lungs. So the lungs are in what we call the pleural space, or the pleural cavity. The mediastinum is our heart, what they call the great vessels, which is our aorta, vena cava. Those all are in the mediastinum. Same thing with the first branches of the pulmonary arteries and the return branches of the pulmonary veins, right? At least the kind of, part immediately connecting to the heart is still in the mediastinum before it actually inserts into the pleural cavity on each side of the chest with the right lung and the left lung. So mediastinum is where we'll be talking about with our cardiac tamponade, our aortic shearing, cardiac contusion, right? Any of that stuff that's right in the middle is the mediastinum. When we're talking about pneumothorax and hemothorax, right, that's over here in our pleural cavity. All right, so first section, right, or first kind of injury that we're going to talk about is rib fractures, but beyond just rib fractures is really getting to that kind of classic, terminology for us of a flail chest or a flail segment. And so a flail chest or a flail segment is when we have two or more adjacent ribs that are broken in two or more places. So that's our definition, two or more adjacent ribs broken in two or more places. So that's where we get really kind of that free floating segment, which is when they say flail segment or flail chest. Right, we get a free floating segment of ribs that has that kind of paradoxical motion where when the patient's breathing, it looks like that rib segment is kind of moving opposite of the chest, the paradoxical movement opposite of the chest. So it's typically some sort of blunt force trauma, obviously. Not too often really a penetrating trauma, because kind of the mechanism behind penetrating traumas is a lot of energy focused down to a single spot, right? That's then going to puncture into the skin, as opposed to blunt trauma, where it's kind of a more distributed force being applied to that body. So it's less likely going to actually puncture and penetrate straight through. So these are more common with your blunt chest traumas. And really it's rib fractures. It's just enough rib fractures that it creates this little free floating segment. So two or more ribs broken in two or more places, two or more adjacent ribs. So not this rib broken and that rib broken. That doesn't fit our criteria of a flail chest, right? It's this rib broken twice and that rib broken twice. And so now we're going to get this little segment that's going to be moving opposite of it. So with it, Right? Like I said, paradoxical movement is one of our most common descriptors that's going to help clue us into specifically a flail chest. Right? They'll say paradoxical movement, right? Or paradoxical motion, or paradoxical chest movement. Right? Everything else is going to fall into the same criteria as a lot of things. Right? So pain and tenderness. Well, that one on its own can't tell me I've got specifically a flail chest. Maybe I've just got some broken ribs. Maybe I've got a strained muscle. Right? So pain and tenderness isn't enough, but it's going to show up with this for sure because they do have some broken ribs. Shallow breathing. Right? The reason why they're breathing shallow is since every time they're breathing, that kind of flail chest segment is moving around too. Right? It causes a lot of pain. And just like anybody with rib fractures, they're probably going to start shallow breathing just because the expansion of that rib cage, the expansion of that chest wall causes more pain. So they start taking little shallow breaths as a form of, almost self-splinting, right? Trying to really restrict the movement and motion of those broken ribs, right? So these white ones here can show up with just a rib fracture. Just a rib fracture, or multiple rib fractures that doesn't fit the criteria yet of a flail chest. Once we add in that paradoxical movement, now that's really, that's the magic word, right? If you get that one, right, you see that one on a test question or something, for example, big giant red flag should go off in your head saying that's a flail chest, flail segment. So paradoxical movement, which we're going to talk about, pain, tenderness, shallow breathing. With the shallow breathing, probably going to become hypoxic. Okay. And the hypoxia is obviously hand in hand, right, with the cyanosis. So those two just make sense. Those are going to happen together. And then as we start to become a little bit hypoxic, our body is going to respond with some tachycardia to compensate. Right? So tachycardia is a compensatory mechanism. And then that tachycardia is also going to be showing up just because the person's in pain. And anytime you're in pain, your heart's probably going to start firing a little bit faster. Okay. So some books will tell us 3 or more ribs broken in 2 or more places. I've seen that like one time. I don't remember what publisher or what book I saw that. They said 3 or more ribs in 2 or more spaces, or 2 or more places. But the vast most common definition is going to be those 2 or more ribs broken in 2 or more places. All right, so what is that paradoxical movement? Or really, how does it actually manifest? And you got to go back to thinking about the respiratory, breathing, right? That ventilatory breathing process, the mechanical process of breathing, right? When we take that breath in, our rib cage expands out. Because when we're breathing in, it creates that negative vacuum that pulls the air in. So the negative vacuum pulls the air in when we breathe in. You should think about that negative vacuum pulling in that flail segment. So when we breathe in and our rib cage expands out, that flail segment piece is going to look like it sinks in. It's getting pulled in by that same negative vacuum that's pulling in the air, because we're all breathing off of negative pressure ventilation, right? So we take a breath in, flail segment sinks down. And then when we breathe out and that rib cage collapses back down, then that positive pressure that's created inside the chest is going to push that flail segment back up, right? So again, the paradoxical movement, you breathe in, flail segment goes down. You breathe out, flail segment rises back up. Right, so it's kind of that back and forth pattern just of that particular segment of the 2 or more ribs that are broken in 2 or more places. Cool. So treatment side for us is a bit more simplified than it used to be, right? Depending on when you came through school initially, right? When I did EMT school, it was, and paramedic school, I think for that matter, it was bulky dressing, tape it front to back, right? Tape it sternum to spine. And it was thought that that would, maybe help kind of splint it a little bit. But the reality is, we have this significant chest trauma, and, taping a big bandage on the front and back is going to restrict the chest expansion, it's going to make it more difficult to breathe, really is the thought process behind why they moved away from that. So now the treatment of the flail chest is really just positive pressure ventilation if they need it, maybe some PEEP on that bagging, right? Just to keep some of that back pressure in there to keep the alveoli open. Because what happens is where that segment is, when you breathe in and that segment drops down, it's compressing on the lung tissue, right? So that piece of the lung tissue that's getting compressed by that flail segment isn't going to be staying nice and open. The alveoli aren't going to. And so we're going to be restricting gas exchange that's actually happening there. And so PEEP helps just kind of keep that, that tissue where the flail chest is compressing on it. It's going to help keep that tissue nice and open and better able to help participate in that gas exchange. So it's really positive pressure ventilation if it's needed. If the patient's breathing well enough on their own, oxygenating okay, vital signs are checking out, then we may not do anything. If they're conscious and alert, maybe they just self-splint, right? And they're going to, probably be protecting that piece of the chest. Right? But the reality is that shallow breathing is likely going to be there. And with that shallow breathing, we need to make sure that they're still oxygenating appropriately, right? That we're still able to get that oxygen into the bloodstream. So if they're breathing too shallowly because of the pain, which makes sense, it makes a ton of sense. But if they're breathing too shallowly, then we'll need to supplement that ventilation with some positive pressure ventilations to make sure that we can get that air really down into the lungs to where we need it to be. The other opportunity, if you haven't, right, is being able to give some pain meds. Right? And this works for the flail chest and the rib fractures, as long as you're not running into any sort of pain management contraindications like hypotension. Remember, we got to kind of reframe this back to, this is a trauma patient. Are they bleeding out somewhere else? Are they in shock? Are they hypotensive? Well, if they're hypotensive, I'm not going to give them any pain meds, right? Because that's just going to be driving the hypotension faster, right? So pain meds, maybe, right? It depends a little bit more on where we're going to be. Right, but gone are the days of the restricted, bulky dressing taped front to back. We just don't do that anymore. A long enough time ago, they would say, put a sandbag on that segment of the chest. Let's think about that. Like, you're laying on your back, maybe backboarded, you're laying on your back on the gurney, and they put a friggin' sandbag on your chest. Right, what's that going to do to your ability to actually breathe? Right? And that's going to be heavily restrictive. Cool. All right. So yeah, treatment side is really positive pressure ventilation, and we're likely making that decision. Whoops. Lost my pen. There we go. Yeah, we're likely making that decision up in our primary assessment, or ABCs, right? Obviously on the trauma skill sheet, when you look at the patient assessment skill sheet from National Registry, it's, identifies any injuries that may impair breathing. Right? So that's really listening, and exposing the chest, right? So that we can actually see what's going on. But we may even get there before we actually find the flail segment or the broken ribs. And we may see, hey, this person's breathing, 28 times a minute shallow. Right? That shallow is typically a magic word that kind of pushes us towards a positive pressure ventilation answer. So we may make that decision on needing to bag our patient prior to actually even finding the flail chest. Right? But in a multiple choice question, they'll give you enough stuff, and they'll, at some point in there, that paradoxical motion will rear its head for you. That if you just recognize that paradoxical motion, you're going to pick up on the signs of this flail chest. But management of it is really just kind of the standard ABC airway and ventilation management, right? So bagging our patient. All right. So pneumothorax, right? Pneumothorax is another one, right? Pneumo referencing air, thorax and the thoracic cavity in the chest. Right? So you split that. right? So air in the chest is what we're dealing with. Air building up in the pleural cavity specifically, which I like this picture when I found one because they show still the outline of that whole pleural cavity space. And they show, be the color change, the compressed lung that's there. Right, so in the pleural cavity, my little anatomy review session for you is there's two membrane layers and there's a little bit of fluid in between to protect them. So we have a membrane layer that's directly on the lung, and that's called the visceral pleura. Pleura just referencing, we're talking about the pleural cavity. Visceral is referencing the organs. So in this case, the organs that are in the pleural cavities are the lungs. That's the only thing that's there. Okay. And then we have another membrane layer on the wall of that cavity. And that one is the parietal pleura. So pleura, again, referencing the pleural cavity. Parietal is the wall. Right, so visceral membrane layer is on the lung tissue. Parietal membrane layer is on the wall. And that's our little anatomy side note on this one. Right, so in this one with pneumo is there's at least some amount of air has entered into the pleural cavity, right? Even if it's just a tiny little bit of air that's actually inside the pleural cavity, then it's a pneumothorax just by definition. Right, as long as we have some sort of air in the pleural space, there shouldn't be any air there. So if there's any air there, it fits the criteria, it fits the definition of being called a pneumothorax. Right, so saying pneumothorax is great, but using some more descriptors to kind of tell us where are we at on the severity scale is going to be better, because that's going to guide our treatments a lot more. Because we could have a patient that has a pneumothorax that we have absolutely no idea they have a pneumothorax. And it's not until they get a chest x-ray and the chest x-ray shows, hey, they've got a little bit of air building up there in the top of the pleural cavity. Okay. But we're not going to be able to see that because it's such a small amount of air. Right, so obviously the more air that's entered into the pleural space, the more compression of that lung is going to be going on, and the more symptoms that patient's going to have, the more difficulty breathing, the more pain potentially, the more cardiovascular compromise, hypotension, the more pressure building up, the more impact on the heart that's there. Right, so we need to figure out where are we at on this kind of severity scale. Okay? And there's two kind of opportunities for what we're dealing with. Right, we're going to talk about open pneumothorax, and we're going to talk about a closed pneumothorax. Right, but some of those signs and symptoms that I said we got to evaluate for is going to clue us into, is this really, really bad? Or is this, maybe just kind of bad, but not so bad yet? Right, we haven't actually determined really that severity scale yet. So one of them is pleuritic chest pain, which is usually described as a sharp and more of a sudden onset. And then it's a good kind of pain descriptor difference if you're comparing like a pneumo to MI, where they talk about that pressure on the heart that progresses and gets worse over time, versus a more sudden onset and sharper pain, typically with that pleuritic chest pain that'll show up with pneumos. Obviously, this is going to be on the affected side. So you always have to remember that our pain complaint and everything is going to be on the affected side. And we're just going to talk about pneumos, but we have to at least reserve that possibility that whatever caused the pneumothorax could have also broken the ribs and caused a flail chest. Right, so we may have compounding injuries showing up on the chest. And if the chest took that much kind of trauma there on that side, maybe the heart's also impacted. Right, so we're going to talk about each of these individually, but we at least have to reserve the possibility that our patient could have multiple of these different injuries that we're going to cover. Right, all right, so dyspnea, difficulty breathing, for sure. Right, diminished, unequal, or absent breath sounds on the affected side. Right, So diminished might just means it's a little bit quieter. Right? And if we thought about listening with our stethoscope here versus listening with our stethoscope there, right, we're going to compare that. Right? This side might sound great, and this side might sound diminished because we're actually picking up, right, some of that dead space. So we're only hearing a little bit of that lung, that breath sound actually moving through the lung. Right? Unequal is that comparison difference. Right? So remember, when we're listening to breath sounds, we're always going to compare side to side. Right? We're going to compare side to side. Absent breath sounds is then if that pneumo has progressed big enough, or our placement on the chest for listening to that breath sounds, we might not be having our stethoscope over, kind of any of that lung field at all. Right? So the more severe it is, it's potentially going to move from just kind of diminished, hey, maybe that one feels a little bit quieter than the other side, to completely absent, where I hear breath sounds, I don't hear anything. I hear breath sounds, I don't hear anything. Right? That's telling us that whole lung is being compressed down quite significantly for it to get to that point. Right? So not all of these are going to show up. It depends on how severe it is. Cyanosis and hypoxia, again, just kind of hand in hand with the difficulty breathing and the diminished breath sounds, where we're not getting as much blood getting oxygenated because less and less and less of that lung tissue is participating in that gas exchange, that external respiration. And then two that we're going to talk about a bit more because it's more kind of technical and it's not terms that come up too often. One of them is pulsus paradoxus. We're going to talk about that one, but that one shows up anytime we have any sort of increased intrathoracic pressure, right? If we're building up pressure inside the chest, that pressure is going to start squeezing on stuff. And so pulsus paradoxus is something that can show up when there's any sort of pressure buildup problem inside the chest. So a more progressed pneumothorax, a cardiac tamponade, the air trapping of a very severe asthma patient could show up with it. So it's a little bit more common of a term with like cardiac tamponade, but it can show up with a pneumo. Right? So we're going to talk about that one. And then percussion. Percussion, actually, pressing on the chest, right? Percussing the chest, where you're kind of tapping it and you're kind of listening and feeling almost that, kind of sonar system, right? Of just how, what's the sound coming back at me when I'm tapping on the chest? And so resonance and hyperresonance is what's going to show up with the pneumothorax. It's going to be the other one that we talk about because, at least for me, when I was taught in paramedic school, percussion just wasn't a thing that we talked about, right? And it still probably doesn't get talked about a whole lot because people either don't know how to do it, don't have experience doing it, don't really have a good kind of comparison, or we end up operating in a pre-hospital setting. And that pre-hospital setting doesn't lend itself well, just kind of on the listening side, to trying to pick up on resonance by percussing the chest. We're going to talk about those two specifically. All right, so pulsus paradoxus, I said anytime you have pressure building up inside the chest, whether it's a cardiac tamponade, which we're also going to talk about, or whether it's, the tension pneumothorax or the air trapping of a really bad COPD asthma patient, right? There's pressure building up inside the chest. And as that pressure starts building up, right, if it's one side like a pneumo, or if it's two sides like cardiac tamponade, right? If there's pressure building up inside the chest, and then we take a breath in, all we're doing is putting even more pressure inside the chest. So we're putting more pressure onto the heart, and we start squeezing the vena cava. The pressure, that air pressure, starts squeezing the vena cava, squeezing the aorta, squeezing down on the heart. And we're really restricting the amount of blood that's going to return into the right atrium, because the pressure on the heart and the pressure on the vena cava is really reducing that blood return to the heart. And so if we have less blood coming into the heart, right, that means we're going to have less blood getting pumped out the heart as well. So what happens is that pressure starts to reduce our blood pressure specifically when we take that breath in. Right? So it shows up again with the increase in thoracic problems. Probably most commonly, if we're talking just test taking strategies and when are we more likely going to see it, it'll probably be your cardiac tamponade patient. But it's at least possible with a pneumo, more likely going to be a tension pneumothorax. And at least possible with, again, a really bad air trapping patient like a COPD, significant asthma exacerbation. But most commonly is cardiac tamponade. So criteria is it's at least a 10-point drop in systolic blood pressure when you take that breath in. Right? So if we could measure the blood pressure for those particular heartbeats, when we took a breath in, that systolic blood pressure has to drop at least 10 points for it to fit the criteria, the kind of technical criteria of pulsus paradoxus. Well, this works well in the hospital if you have like arterial blood pressure monitoring, where the arterial blood pressure monitoring is picking up on the blood pressure of every particular heartbeat, right? Every pulse of blood that's going through, they can say, what was the blood pressure of that heart contraction? What was the blood pressure of that one? What was the blood pressure of that one? And so when you're seeing blood pressure on a beat-to-beat basis, then you can watch your patient and see, hey, they took a breath in, blood pressure dropped. They breathe out, blood pressure came back up. Breathe in, blood pressure dropped. Breathe out, blood pressure comes back up. Now, we don't have that. We don't have arterial blood pressure monitoring pre-hospitally. So people are saying, well, that's fantastic, but I'm not actually going to be able to assess it. And the reality is we can, but we have to get creative. Right? What we end up doing is we palpate a pulse. And we're not going to get the number like, hey, was that at least 10 millimeters of mercury? Was that at least a 10-point drop in systolic? That part we're not going to know. But what we can feel is they take a breath and the radial pulse disappeared. And then they breathe out and I can feel the radial pulse again. And we breathe in and the radial pulse disappears. Breathe out, radial pulse comes back. Right? Or at the very least, it weakens significantly. So we can feel the difference, and then we compare that to the visual of watching our patient breathe. And we say, hey, that heart, that kind of pulse strength gets weaker when that patient takes a breath in, right? That's cluing us in significantly that there's some pressure problems building up inside the chest. Doesn't necessarily on its own tell us exactly what the issue is. Maybe it's cardiac tamponade, maybe it's tension pneumo, maybe it's something else, but that's at least telling us we've got some pressure problems going on up here. And this whole area is very critical on the whole breathing and circulation process. So we need to really get going and figuring out what's going on up here. If it's a tension pneumothorax, we have some options. If it's cardiac tamponade, not really as many options for us pre-hospitally. But that's what it is. It's at least a 10-point drop in your systolic blood pressure when the patient takes the breath in. That blood pressure drops. So we feel that just by the pulse strength dropping and rising. All right, so sliding closer to our treatment stuff for pneumo is we have to at least figure out initially, are we talking about an open pneumothorax or a closed pneumothorax? Right, an open pneumothorax is, let's say, a gunshot wound, right? They got shot in the chest. Right? And what's happening is that opening possibly punctured the lung, possibly didn't, but at the very least, it punctured the pleural cavity. And some of the outside air is now able to get inside the pleural space. And sometimes that outside air is enough pressure that it compresses the lung, it collapses the lung. And then depending on the wound, some of those wounds kind of self-seal over. And now we've trapped all that extra air that's in there. Right? If it doesn't seal over, then it still stays an open pneumothorax. We call that the sucking chest wound, right? Is because that air kind of keeps going in and out, right? And in addition to that air pressure kind of compressing the lung, we obviously have the infection risk of now outside stuff getting into the body because of that puncture. Right, so that's open pneumothorax. Closed is maybe something just kind of popped the lung, so to speak. The chest wall is intact. There's no opening. They weren't shot through the chest. There's just that pressure, like maybe the primary injury of a blast wave, a blast injury. That primary injury is a pressure-driven injury. That could be more causing of a pneumothorax, potentially. Or somebody that holds their breath before they're going to get into a car accident. They kind of hold their breath and hold that air in. And then, you know, maybe their chest hits the steering wheel in a car accident. And because they've kind of trapped that air pressure in there, that when they get that big compression force, has the potential of popping the lung or rupturing the lung. So enclosed, right? So enclosed, the chest wall, again, the chest wall is completely intact. There's no penetrating injury, but there's now a hole in the lung that's allowing air to leak out. Every time they take a breath, some of that air goes into the pleural space, and it builds up and builds up and builds up from there. Good. So it's really just, is the air entering into the pleural space from the air that they're breathing in, or is the air entering that pleural space from like kind of directly from the outside environment? And that's how it's actually entering into the body. Right, so open versus closed. Right? The first step in treating an open injury is make it a closed injury. That's what we'll talk about. In a closed pneumothorax, then it's just figuring out whether it really fits our criteria of like tension pneumothorax, and we have those options. Otherwise, we're looking at, you know, kind of preliminary just airway breathing circulation management. All right, so the kind of full-scale progression, right, we said if there's just a teeny bit of air inside that pleural cavity, it fits the criteria of a pneumothorax, and they'll typically call it a simple pneumothorax. But as it progresses, right, where more and more and more air pressure builds up in there, more and more pressure starts building up, we'll slide over to this terminology of calling it now a tension pneumothorax. And in tension pneumothorax, what they're showing here on this chest x-ray is this big dark spot is all air, right? Normally it's kind of grayish white, like we're seeing on that side. That's the lung tissue that's there. On that side, just that big dark black spot there is air, right? And the lung is actually compressed down over here. Right? So tension pneumothorax, right? Signs and symptoms. Now this is a great visual to show us, hey, if I listen to breath sounds here, they're going to sound great. If I listen to breath sounds here, absolutely nothing. I listen to breath sounds here, sound great. I listen to breath sounds there, absolutely nothing. Right, so absent breath sounds on the affected side is a big one for tension pneumothorax. Okay? More so than beyond just the diminished breath sounds from earlier. Right, so we still have all those other signs and symptoms of a pneumo, just some of these are now going to show up with tension pneumothorax. So take that last list of signs and symptoms of a pneumo, pain, difficulty breathing, pleuritic chest pain, right? And now add in completely absent breath sounds, right? Unequal chest rise, because we think we get chest rise and fall just based on that lung expansion when we bring air in. So if we bring air in, but it only fills up one chest, then one side of the chest is going to rise. Right? So unequal chest rise. And this is one I've actually seen it recently, that the paradoxical movement of a flail segment causes a lot of confusion with people when we also talk about unequal chest rise and fall. Right? Unequal chest rise and fall is the entire, you know, this side of the chest rises, this side doesn't. Paradoxical movement is the chest rises and falls, but this segment goes opposite of it. So it's such a good one to help you differentiate on the multiple choice test, which is really what we're talking about, right? Because if we see the patient, it'll make sense. We see that little segment of ribs there floating around, it makes sense. But when they use phrases like this on a multiple choice question where we can't visualize the patient, then we have to get clear on what it is that they're describing to us. So that paradoxical movement is that flail segment moving opposite of the chest. Unequal chest rise is the whole chest. If this side rises and falls with breathing, this side doesn't. Not just one piece, the entire side doesn't. So that unequal chest rise and fall will show up because there's no expansion of the lungs on this side here. Pulsus paradoxus, again, if you're going to see it in a pneumothorax, it's likely going to be here in the tension pneumothorax. Jugular vein distension is another one very similar, kind of conceptually based on the cause as the pulsus paradoxus, is there's all this air pressure building up inside the chest, and part of that air pressure starts to squeeze on the superior and inferior vena cava. And so when you start squeezing that air pressure on the superior vena cava, less blood is going to be able to enter the heart, which means more blood is backing up, and we'll see it with JVD. That's another one, not on its own can we call it a tension pneumo, right? Because both pulsus paradoxus and jugular vein distension are big ones with cardiac tamponade recognition. But cardiac tamponade won't have absent breath sounds. Cardiac tamponade won't have tracheal deviation. They can have pulsus paradoxus and JVD, but so can tension pneumo. Right, so it's good. You have to start looking at what's different between these different types of injuries. So pulsus paradoxus and jugular vein distension, again, those two are big, just showing up when there's any sort of significant increased pressure inside the chest. You'll get those. Right, so tension pneumo, cardiac tamponade, other big pressure problems. Those will show up there. Absent breath sounds on one side, tension pneumo. Tracheal deviation, we'll talk about tension pneumo. In tracheal deviation, it's hard to see here, but there's the faint outline that kind of curves over here. Right? That's the trachea. Right? That's the trachea that those arrows are actually kind of pointing to. Right? There's a slightly darker outline there that you can actually see it. I know for the longest time I would look at chest x-rays, and if it wasn't like a super obvious broken bone or a big obvious black spot like this, I would look at the chest x-ray and be like, I've got no idea what I'm looking at. So I was starting to get a little better over time. But tracheal deviation is a very common descriptor given to us in a question to help us differentiate that we're dealing with a tension pneumothorax. Right? The reality is tracheal deviation is a very, 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 very late sign of a very significant tension pneumo. And what it is, you got to think the trachea and the lungs and everything is kind of a fixed focal point, you know, higher up in the neck. Right? So as that air pressure builds up and builds up and builds up and builds up, eventually it starts to push that whole anatomy out of the way. Right? Because that air pressure is actually pushing the heart, pushing the lungs, pushing everything, and it starts to bend everything at the trachea. Right? So we'll actually see the trachea will be shifted, right? Or shifted at least at an angle. Right? So tracheal deviation, very, very, very late sign, but it's a very, very, very common descriptor to tell us we're dealing with a tension pneumothorax as opposed to a simple pneumothorax or some other injury. Okay? So absent breath sounds on the affected side, and tracheal deviation, and remember it's going to deviate away from the pneumo because it's the air pressure pushing everything away. So if you see the trachea pushed off to the side, you've got a tension pneumo on this side. If you see the trachea deviated off to that side, you've got a tension pneumo on that side and it's pushing it. Right? So it's absent breath sounds on the affected side, tracheal deviation away from the affected side because the affected side is pushing the anatomy out of the way. Good. All right, so management, right? ABCs and oxygen as normal. And I put positive pressure ventilation here as needed, right? And I put that little asterisk there. And the reality is, we said this whole thing is a pressure problem building up inside the chest. And so if we start bagging the patient and they've got a hole in their lung, right? Us bagging the patient is going to be making that problem worse because we're going to keep forcing more air into that pleural space. So positive pressure ventilation has the potential to worsen the problem in a pneumothorax. But if it's needed, it's needed, right? If they're hypoxic, they're cyanotic, they're breathing very shallowly, they're in bad shape, we need to get the oxygen in. We're just understanding that by bagging them to do it, we have the potential to be making the problem a little bit worse. So it's really just a risk benefit. We can't let them become so hypoxic that their whole system just crashes and they code. But bagging our patient, we know is going to, potentially worsen that problem, right? But we can deal with this problem more so than we can deal with them crashing because of hypoxia. So if they need it, they need it. We'll bag our patient. We're just going to understand that that process is going to potentially worsen the problem faster. And so we're going to be keeping a closer eye on the progression of the pneumothorax signs, right? Like, are we moving faster towards a tension pneumo? Right? But the most important thing is if they need it, they need it. So don't withhold ventilating from the patient if they need it. But if they're breathing okay on their own, maybe let's try a non-rebreather. All right, if it's an open pneumo, sometimes they'll phrase it this way. They'll say, convert it to a closed injury. And every single time I've seen that question, we use a similar question like that. And students ask us and they say, the hell does that actually mean? What are you talking about? Convert it to a closed injury, right? So remember, if it's an open pneumothorax, think sucking chest wound, right? And the issue is that extra air that's being able to come into the chest, right? Because when they breathe and they create that negative pressure vacuum, it pulls air in here in addition to the breathing. But the air coming into that open injury is causing the problem to get worse. So first thing we can do is stop the problem from getting worse. So converting it to a closed injury is actually saying, put your gloved hand over the opening, over the open injury. And a lot of people, right, they start to think through, especially when you see a treatment-based question and you see, needle decompress, put an occlusive dressing on, convert to a closed injury and something else. And a lot of people, they go right away, sucking chest wound, occlusive dressing. Okay. But I don't know about you, but I'm never just walking around with an occlusive dressing ready to go. And that's how you have to think about it. You have to think, do I have this equipment just in my hand ready to go? Not usually, right? Not an occlusive dressing at least, right? So first step is gloved hand, cover the wound. Second step, we can go get an occlusive dressing. And then that way we can have our hand back, right? But the first step right away, just like direct pressure with bleeding control, right? We do that right away because we're also typically not walking around with a tourniquet ready to go. We do direct pressure right away because it's faster. We always have our hands, right? Cover a sucking chest wound is faster because we always have our hands. And then somebody can go get occlusive dressing. Or in the case of a bad bleed, somebody can pull out a tourniquet. But in the meantime, we got intervention going right away just by using our hand. So when they phrase it that way, convert to a closed injury, is saying, cover the wound with your gloved hand. That's it. And that only matters if it's an open pneumothorax, a sucking chest wound. If the entire chest wall is intact and we're starting to identify that they've got a pneumo, there's nothing for us to cover. So it's only for an open pneumothorax or that sucking chest wound, or a gunshot wound. All right, on the occlusive dressing, okay. So if you've got a sucking chest wound there, right, most occlusive dressings will talk about, taping on at least 3 of the sides, right? so that as this air pressure builds up and builds up and builds up, the air pressure will eventually kind of burp itself on the side of the occlusive dressing that's not taped. And then the negative pressure vacuum will kind of pull that occlusive dressing tighter back down onto the chest. Right, so by only taping 3 sides, and some places, you know, protocols might say tape all 4 sides as possible. And so if they tape all 4 sides, you just have to remember that that pressure is never going to be able to relieve itself. So if you're assessing that patient and you see, hey, we put on occlusive dressing, we taped all 4 sides, and now it looks like they're progressing to a tension pneumothorax, then maybe you just peel off that occlusive dressing, let that air pressure to relieve itself, and then put it back down. Right. That's a big one on the open chest, the open pneumothorax. Right. Certainly on the medic side, where we talk about needle decompression, they already have a hole in their chest. We don't need to needle them and add another one. Let's just burp that occlusive dressing. Right. So that's if you tape all 4 sides. If you tape 3 sides, much more likely you're going to allow that air pressure to release. Or if you have some of the commercial made chest seals, like the Halo chest seal, I know is one of them, they have a built-in little kind of valve flap that will allow that air pressure to relieve itself as it starts to build up too high inside the chest. Okay. So occlusive dressing, right? So that split right there is BLS, right? BLS before ALS. Okay. So again, it's another one on the medic side. If you're looking through a treatment question and it says, put a gloved hand on, put an occlusive dressing on, needle decompress, and something else. And you can look at that question and those answers and you can say, I'm going to do all 4 of those things. I'm going to do all 4 of them. That's where some people get so twisted up on National Registry is they look at it and they say, all 4 of those are correct. And that might very well be true. But what that means is they're asking you, what's your order? Which one of those answers are you going to do first? All right, I'm going to convert it to a closed injury first. And if it's an open wound, I'm going to do that. And then I'm going to do an occlusive dressing. If it's a closed wound and that air pressure isn't relieving itself, then maybe my next step is to needle decompress. Right? So needle decompression is typically that one's going to show up on a closed injury because there's no route for that air to relieve itself. So we have to put the needle in to allow that air pressure to relieve itself. The occlusive dressing gloved hand, that's an open wound, so that air pressure can relieve itself because there's a hole there already. Perfect. All right, and last one, and then we'll probably take a short little break here, is needle decompression, also called needle thoracentesis or pleural decompression. Right? Remember, everything in medicine and in our textbook and EMT and National Registry and everything, always be thinking through how else can they phrase it? What else is it called? So if they don't say needle decompression, but they say needle thoracentesis or pleural decompression, you need to know what that actually means as well. All right, so this one, the needle decompression indications for us is we've identified and we're saying our patient has a tension pneumothorax. So they've got absent breath sounds on one side, some sort of chest trauma mechanism that supports it, maybe that tracheal deviation, which even though it's a late sign, like I said, it's a very common descriptor in a test question. So we see something and we say, hey, I'm calling this a tension pneumothorax. Hypotension is another one for a tension pneumo and altered mental status, right? Hemodynamic compromise or cardiovascular compromise. So if you have absent breath sounds and they're hypotensive, it's telling you that that problem is progressed enough. Or absent breath sounds and they're altered. Again, it's telling you that that issue is severe. Right? So any sort of hemodynamic compromise, cardiovascular compromise, in addition to those absent breath sounds, is good criteria things for us to say this is a tension pneumo. So maybe I'm going to needle decompress. Right? We are always figuring out where are we at on the severity scale. Right? In ACLS, we do that. Are they stable or unstable bradycardia? Are they stable or unstable tachycardia? Is it a simple pneumothorax or is it tension pneumothorax? Is it a mild allergic reaction? Is it anaphylaxis? we're always figuring out where are we at, because we'll do different things depending on how severe the problem is. So in a tension pneumothorax, where we're seeing that the problem is very severe, we're going to needle decompress if it's a closed injury and we need to relieve that air pressure. Okay. So the two most common sites are second intercostal space mid-clavicular and or fifth intercostal mid-axillary on the affected side. Okay. So if this is patient's right, and that's where we have the absent breath sounds is on the patient's right, right? We can look at it and say, okay, here's intercostal space number 1, and here's intercostal space number 2. Okay. So I'm going to find my clavicle mid-clavicular line. Move that out of the way. There's my clavicle mid-clavicular line, second intercostal space. Some books may say third intercostal space is an acceptable spot as well, but second intercostal is probably going to be a little bit more common. So second intercostal mid-clavicular, so find your clavicle, find that halfway point, and then drop it down to that second intercostal. Okay. That's all the way back to that very first slide where we said we got to figure out which intercostal space are we actually dealing with. Right, so if you form that little triangle, put that finger in your sternal notch and dig in and find that first space, that's your first intercostal space. Now you can palpate down and say, okay, that means there's my second intercostal space, and I'm going to walk my way over, and there's my mid-clavicular line, so that's the spot. Right, that's where I'm going to go. Fifth intercostal, okay, so if that's 2, when you go down, all right, that's 3, that's 4, that's 5, and then mid-axillary is kind of the mid-armpit line. So fifth intercostal mid-axillary is another possible site of needle decompression. That's typically where you'll see a little bit more like chest tubes placed, is they'll go that mid-axillary, probably fifth intercostal space. So these are our 2 more kind of textbook sites, but there may be some kind of variability to it. Cool. So second intercostal space or fifth intercostal mid-axillary, and they'll always phrase it as just above the bottom rib in that space. And so what happens is if we had 2 ribs, right? This is rib, this is a rib, and this is the bottom rib, right? Running right underneath the bottom border of the rib is what we call a neurovascular bundle, which is a little vein, artery, and nerve that runs just beneath each rib. Okay. So that's that, right? Just beneath each rib. So if we identify that this is our second intercostal space, right, between these 2 ribs, right, we're going to want to needle decompress. We're going to want to push that needle through just above the bottom rib to try to avoid puncturing any of the nerves and blood vessels that are running there just below the rib above it. Right? So a lot of people will say, find the rib, hit the rib with the needle, and then walk it up and over the top, and then insert it right there. And again, we're just trying to avoid any extra damage to that neurovascular bundle. If you look really close on this picture, you can see a little blue and red line right underneath each rib. That might be a little bit difficult. It's pretty dang tiny. So just above the bottom rib in the second intercostal space, which is between ribs 2 and 3, or the fifth intercostal space, which is between ribs 5 and 6. And putting that needle in just above the bottom rib, again, mid-clavicular, on the affected side, or fifth intercostal mid-axillary on the affected side. And we don't want to needle decompress the wrong side. So whichever side has the absent breath sounds is where we're trying to relieve that air pressure from. All right. Let's take a short little break here. Right? I want to get through hemothorax with us, and then cardiac tamponade. That's where we're going to spend a good chunk of the rest of our time. And then real quickly, we're going to touch on some of the other ones, aortic shearing, cardiac contusion, commotio cordis, are some other ones, but those are going to be a little bit more straightforward. There's kind of less stuff to talk about with them. And pneumos and cardiac tamponade are probably more commonly asked about questions anyways. So it's going to be a good conversation. So let's take a little 10-minute break and stretch your legs, get some coffee, whatever it might be. Let's do a 10-minute break, and then we will jump back in here to hemothorax, tamponade, and everything else. Cool. See you guys back in a few. All right. So back where we left off is hemothorax. Right. Hemothorax is now we have blood building up inside the pleural cavity. Right. Instead of air building up inside the pleural cavity, which is our pneumothorax, now we've got blood building up in there. And that blood that's building up is what's actually starting to achieve a similar thing, which is added pressure kind of compressing down on the lung tissue. Right, so air will rise to the top, blood by gravity will sink to the bottom. Right? So it just depends on how much blood it is that we're talking about. So blood in the thoracic cavity, blood in the pleural cavity is a hemothorax. Right? Signs and symptoms, some similar ones as the pneumo: difficulty breathing, cyanosis, hypoxia, right? Chest pain because of whatever caused the bleed in the first place, right? But then some of the different ones is the neck veins, right? So in pneumothorax, tension pneumothorax, we said that added pressure caused the back pressure, and we saw the jugular vein distension. Hemothorax, when you think about it as a significant, potentially massive internal bleed, right? So we're seeing some hypovolemic shock signs and symptoms. We see flattened jugular veins because they've been bleeding out into their thoracic cavity, right? So JVD, pressure building up, JVDs, tension pneumothorax. Flat neck veins, flat jugular veins, is they're bleeding out. There's less blood in those pipes. And so the flat neck veins is going to be one of the helpful ones for us. Other just hypovolemic hemorrhagic shock signs and symptoms: cool, pale, clammy skin, hypotension, right? All of those are potential ones. Breath sounds certainly have the potential to be diminished as well on the affected side. And then dullness on percussion is what we will see with the hemothorax compared to the resonance or the hyperresonance on percussion with a pneumothorax. We're going to talk about those here still in just a second. Treatment for us, we're really looking at general ABC shock treatment, right? General ABC shock management, fluid boluses, bagging the patient if that's what's needed, certainly the high concentration oxygen, but the rapid transport, because wherever that bleed is coming from is a significant possibility that they may need surgery to stop that bleed. So it's one of those trauma patients that's, hey, nothing we're going to do is really going to help stop this process. So let's get them to the trauma center rapidly. So treatment for us, very much ABC shock management, fluid boluses if we can, and rapid transport. It's pretty straightforward on that side. So percussion. Percussion. Dullness is telling us that the chest, or that side of the chest, is full of fluid. And in trauma, most of the time, we're assuming that that fluid is blood. Hyperresonant means it's full of air, it's hollow. Now, the example that I've always kind of utilized and thought about is if you think about finding a stud in the wall, right? Every single one of you can walk around the room right now and just bang on the walls, right? And when it changes, right? When that sound changes from that hollow sound, right? Hollow sound, hollow, what's that L? Hollow sound to that more solid sound when you find a stud. Right? The stud that you found is the dullness. That hollow sound is the hyperresonance. And so it matches. The hollow sound is, there's nothing there, it's full of air. The dullness is, it's full of something, right? It's a stud in the wall or it's fluid that's built up in it. The other example, or another easy one for you guys to do, is get a two liter bottles, right? Or 2 plastic bottles of any kind. Right? And I've got 2 here. I don't know if the sound will come across properly, right? So get 2 bottles, one of them full of water or soda, whatever, it doesn't matter, and one of them that's empty, right? And if you start tapping on them versus, and I have no idea if that sound came across to you guys at all, but get it, run a little science experiment yourself. Get a hollow bottle, tap on it, listen to that hollow hyper-resonant sound, and think that's air that's built up inside the pleural cavity. That's a pneumothorax. Versus the sound change when it was full of fluid, and that's dull. So it's full of fluid, that's a hemothorax. Hey, perfect. I appreciate you guys saying it came through. I also thought about it for a second. I was doing it like that. I was like, I'm gonna get water all over my computer and this whole Zoom session is just gonna shut down on us. Cool. I'm glad that worked a little bit. But yeah, get it yourself, because that's what percussion is. It's auditory wise, being able to say, that's hollow, and that's definitely not hollow. It's a completely different sound. And so that's what we can actually feel, right, or generate by percussing on the chest, right? Again, not a skill that's talked about, not a skill that's really taught super well. It's a great thing on clinical shifts to interact with doctors and ask them about percussion, because they're much more likely to do it regularly. I don't know many medics that percuss at all, but it's such a simple thing that if you can just remember dull versus the resonance for full of fluid versus full of air, I mean, that could be one of those things that you see that word and you're like, bam, pneumothorax. Right? I mean, there's going to be other signs and symptoms in that question, that multiple choice question, that's going to clue you into that. But it could be one of those words that if you just remember that word, you know, it's one of those big red flag ones in your brain that I was talking about, right? That's the answer, right? It's telling you exactly what it is. So I can't encourage you enough to get a couple plastic bottles and do that yourself, just to really, you know, really understand what it is that actually sounds like and what that actually feels like. All right, real quick question. Can you go back to the last slide for about 5 seconds? Yes, I sure can. Perfect. There you go. So yeah, hemothorax, dullness. Cool, you bet. All right. So again, hemothorax, shock management, fluid boluses for hypotension, and get them to the trauma center. All right, cardiac tamponade, right, is now remembering that we have that pericardial sac surrounding the heart that's full of fluid. Right? And in cardiac tamponade, it's fluid. In the context of trauma, we're assuming that it might be blood that's filling up, and there's blood that's building up in there, and it's actually increasing the pressure kind of being squeezed onto the heart just because that added blood. Typically, the mechanism is going to be more of a penetrating trauma to the chest, and penetrating trauma where it actually damages the blood vessels and everything that's there. So it's that blood filling up in the pericardial sac, but you can get cardiac tamponade where it's fluid that's building up because of cancers or infections, other things. So officially, it's just fluid building up in that pericardial sac. And then again, in the context here with trauma, it's going to be the blood that's filling up. Again, typically our mechanism is going to be a penetrating trauma. Right, a lot of the other ones so far have been probably more blunt trauma, hemothorax, something, you know, ruptured some blood vessels. So that one's probably a bit more penetrating potential. And this one with cardiac tamponade, probably more penetrating trauma mechanism. All right, so the 3 classic findings don't always show up, but the three classic findings that will always show up for, you know, kind of national registry questions is Beck's Triad. So Beck's Triad is the three variables that your brain should lightning fire pick up on if you see them in a scenario question. And so Beck's Triad is the three, again, that show up with cardiac tamponade, and we'll talk through them. It's narrowing pulse pressure, muffled heart tones, and JVD. And so we said, just like in pneumothorax, let's work our way from the bottom back up to the top. In pneumothorax, we said that air pressure is squeezing on the heart and it's squeezing on the vena cava. So there's less blood that's able to get into the heart, which means more blood starts backing up and we get JVD, right? So in this case, it's the exact same thing, that there's pressure pushing on the heart. But in this case, instead of air pressure from the pneumothorax pressing on it, it's the pressure in the pericardial sac that's compressing on the heart. And so all of this pressure is really just compressing on the ventricles, compressing on the atria. It's putting more pressure on the heart. So it's allowing less blood to get in, which again, like I said, is going to mean more blood will start backing up. Right? And so it's pressure on the entire heart, which means it's going to back up more systemically. Right? So our lungs probably going to be clear still, right? But the blood is backing up systemically. So we're going to see it with JVD. Right? So again, JVD, we said, was one of those that's just an increased intrathoracic pressure symptom. Maybe that increase in intrathoracic pressure was the tension pneumothorax. Maybe the increased pressure inside the chest on the heart is just the cardiac tamponade. Right? So JVD shows up. Muffled heart tones is actually getting your stethoscope out and listening to the heart tones and remembering that heart tones are our valves snapping shut, right? That's what we're actually hearing when we're listening to that bump, 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 right? That's the valves snapping shut that's there. So the valve snapping shut is what we're hearing. So if the entire heart is just constricted and it's not able to open up much and contract much, right? Instead of like this, you know, big, nice, good contractions, now it's just open, close, open, close. It's a lot weaker of a contraction. There's not as much force there because of all that pressure that's being pushed on it. So now instead of the valves really opening and snapping shut, they're opening, you know, and just being compressed. Those valves are closing a lot more gently, so to speak, a lot softer. Right? So we're listening to the heart through a bunch of fluid, and then the heart contractility is just weakened because the heart's not able to really expand much and have good, strong contraction. It's only filling up a little bit and contracting a little bit. So those heart sounds are actually quieter, right? Or muffled is the word that they use for them. Now, the only way that you're going to be able to pick up on muffled heart tones is if you listen, obviously. But you really need to listen to heart tones regularly to understand what they sound like normally so that you get a better idea of when they're muffled. Right? If you listen to heart sounds all of the time, when you finally hear muffled heart tones and that kind of auditory difference between the two of them, it'll stand out to you a lot more easily, right? If you never listen to heart tones, except when you think that it might be cardiac tamponade, then you don't have as much of a foundation comparison of what's normal to what's abnormal, what's normal to what's muffled. So the more normal you listen to, the more abnormal is going to stand out to you. Right, that's just good practice. All right, narrowing pulse pressure is our systolic and diastolic numbers get closer and closer together, and they're going to be going lower. Right? They're going to be going hypotensive. As we said, if less blood is coming into the heart, that means ultimately out the other side, we're only going to be pumping out less blood. Because if less blood makes its way in, less blood is going to make its way through the heart to get pumped out to the other side. So they're going to go hypotensive, but because of all of that pressure on the chest, it's saying that there's not much of a difference between the higher pressure contraction and the lower pressure relaxation because of all that external pressure being applied to it. Is the contraction and relaxation is not that different of a pressure. And so it's where you'll see you know, blood pressure is like, you know, 88/70, right? Systolic and diastolic numbers are getting closer together. Right? If they don't give you one set of vitals that looks particularly close, then maybe a question will give you two sets of vitals and say, hey, their blood pressure was 100/70, and 5 minutes later, it was 90/72. And so we look at those numbers getting closer together on subsequent sets of vitals. And that's a narrowing pulse pressure. So narrowing, and again, the expectation that that blood pressure systolically is going to be dropping towards hypotensive if they're not hypotensive already. So those are the three for Beck's Triad. And again, those, I want you to be able to pick up on those really easily, because that'll be just a very good test question situation. Other things that'll show up: tachycardia to compensate for the hypotension, potentially hypoxia, just depends on how well we're circulating blood. Right, so we'll get other things too, but these are the three that you get those three, your answer, that's Beck's Triad, your answer is cardiac tamponade. All right, another one that can show up with cardiac tamponade that doesn't get talked about very often is this electrical alternans. Right? And electrical alternans, right? It's the electricity is alternating, right? And so we see big complex, little complex, big complex, little complex, big complex, little complex, right? And it's that contraction of the heart with cardiac tamponade, and that fluid shifts. And it allows the heart to expand a little bit differently, maybe more. And that next one is a bigger contraction, a bigger electrical depolarization. And then that fluid shifts. And then the next one, the heart can only expand a little bit. So it kind of keeps getting this pattern that's there. And what's happening is this fluid is actually shifting inside that pericardial sac. Every time the heart contracts, that fluid is able to shift. And then the heart's going to expand differently and contract differently, and then that fluid is going to shift. So electrical alternans is just the big, little, big, little, big, little of our QRS complexes. If you see that one, certainly in the context of pulsus paradoxus, certainly in the context of the Beck's Triad, right, that's going to be our cardiac tamponade patient for sure. All right, so management for us is normal ABC shock management and fluid boluses to try to keep that blood pressure up. That's really it, right? If we've got, you know, this big blood engorged pericardial sac, nothing that we can do anything about, right? What they need at the hospital is called pericardiocentesis, where they'll put the big needle up under the rib cage, and they'll put the big needle into the pericardial sac to pull off that blood, right? To drain off that extra blood. We pull off the extra blood from the pericardial sac. It's going to allow that heart to start expanding a lot more again. Right? Then they're just going to figure out where that blood come from. Right? Is there a puncture to one of these blood vessels? Did it heal itself over? You know, is surgery needed? Or can they just relieve that blood pressure that's being pushed on the heart and then monitor that patient from there? So in hospital, they need pericardiocentesis. That's not something that we're allowed to do. So really we're stuck at just ABC management, right, as normal, and then shock treatment, fluid boluses as needed to kind of maintain an appropriate enough systolic blood pressure. All right, some other ones working our way through is cardiac contusion or myocardial contusion is another one, blunt trauma to the chest. Maybe it's a secondary impact, right? When we talk about car accidents and trauma, we'll talk about a car versus tree is the primary impact. And then the patient that's in the car, they continue forward, they hit the steering wheel. That's the second impact. And then your organs continue forward and hit the front of your body. That's the third impact, right? So maybe a cardiac contusion is the third impact, right? Is that patient's body came to a stop, but then the organs kept going forward. And that heart hit the front of the chest with enough force that it caused a bruise, right? Because that's what a contusion is, right? It's a bruise. Maybe it's just a significant enough pressure force being applied to the chest. But again, typically blunt trauma, and it causes a bruise to the heart, right? Bruise to the heart muscle. So you've got damage to the tissue. And then in a big one that will show up is impairment of electrical conduction, right? The electricity doesn't flow well through injured tissue. It's why we get some of those ECG anomalies and a myocardial infarction, is that electricity just doesn't move through injured tissue, certainly doesn't move through dead tissue, but doesn't move through injured tissue as well. Right? So blunt chest trauma, cardiac arrhythmia, or if they just tell you a heartbeat that's irregular, that's going to be a very common thing that's going to push you towards a cardiac contusion, a myocardial contusion, is they'll say the heartbeat is irregular after some sort of blunt chest trauma. It can be other things, but that's a very common one that they'll use to describe to you a cardiac contusion. All right, so one question is, can it cause a rupture to the aorta? Rupture to the aorta. Not the cardiac contusion on its own, but if the heart, kind of got jostled around in there enough to hit the chest wall with enough force, it's possible that it could also shear or rupture the aorta. So that one's going to come up, we'll talk about it. So not a cardiac contusion on its own will cause a ruptured aorta, but whatever sort of traumatic mechanism of injury they experienced, if it had enough force to move around the heart to cause a contusion, it might have enough force to move around the heart where it actually shears or ruptures that aorta as well. So cardiac contusion, again, the impairment of the electrical conduction, or in a kind of written scenario question, a patient that doesn't have a history of AFib, it's not anything like that on the medical cardiology side. After a blunt force trauma to the chest, one of the symptoms that they have is an irregular heartbeat. That's, again, a very common kind of way that we can start to describe to you that, hey, a cardiac contusion might be what they've actually suffered. It's not the only thing that can cause it by any stretch, but again, it's a more common way that a question like that might be phrased. All right, so aortic dissection or traumatic aortic disruption or aortic shearing. Again, there's enough movement of that heart. And remember, the heart kind of hangs there in the chest a little bit, and it's kind of anchored more or less by the vasculature and everything up top, right? That's where you're getting a lot of the support for it. So if that heart moves around a lot, it can shear from where that support is. And that shearing can take place on the aorta, right? So some of those fixed points are the remnant of the ductus arteriosus from fetal circulation, which is that blood vessel between our pulmonary artery and our aorta, allows for some mixing in fetal circulation. After we're born and that blood vessel closes off, there's still a little bit of tissue that's there called the ligamentum arteriosum. Right? So that can be a site that can cause the shearing of the aorta. Once we move into the descending aorta, there's kind of the anchor spot for the aorta to the thoracic wall. There's a little connection there between the descending aorta and the thoracic wall. And so that's another one, just a more fixed spot up top, that if that heart moves enough and that aorta is kind of, attached to the thoracic wall, then that heart moving, it can shear the aorta on that descending aorta. Obviously, at that point, it's going to be significant hemorrhage internally. So the treatment for that is really just ABC shock management, fluid boluses, 2 large 4 IVs, but really super rapid transport to surgery is what they need. I kind of skipped over the cardiac contusion treatment. That's another one. We're really stuck at just general ABC shock management. There's nothing specific that we're going to do for the cardiac contusion. There's nothing specific that we're going to do for the aortic dissection. We're just trying to keep our patient alive. So we're at just general ABC shock management, nothing extra special there. Commotio cordis is another one, blunt trauma to the chest, blunt trauma to the chest. It may be contextual with the later development of like a cardiac contusion or something else. But this injury specifically is when we have, let me change this to black so it's a little bit easier to see. All right, when we have on the monitor, here's our kind of ECG, right? There's a little window right here on the upslope of the T wave that if somebody, while the heart is repolarizing, recharging, right, if they took enough force or impact or kind of energy being applied to the heart during the upslope of that T wave, right, what can happen next is VFib, right? And it's purely just bad timing. It was enough force at just the wrong point of time, right? Just on that early repolarization, right? So just on the upslope of the T wave. And if they took enough force, enough impact, enough energy being applied to the chest and the heart while the heart is recharging, what happens is you kind of get competing electrical signals, right? The heart's trying to recharge and then it's taking a force that's trying to make it, you know, almost in a way depolarize again. And so if that happens, they'll slide over into something like VFib and you'll be working a code, right? And then you're working a code like normal ACLS. We're just remembering that this was contextual with a trauma situation. So it's an electrical problem. Generally, it responds pretty well to electrical interventions. So defibrillation and our normal code working, it should work pretty well. A more common scenario, right, might be a person takes a baseball to the chest and then they collapse and they're in cardiac arrest. Right, and it was that baseball hit him in the chest at just that point in time with just enough force that it sent them into that lethal arrhythmia. Right? That's why you see, you know, some baseball players in little leagues and stuff like that, they put chest plates on the kids. And it's trying to say, hey, if that baseball hits that chest plate, it's going to help distribute that energy a little bit more so that it doesn't all get applied to the heart and we hopefully avoid commotio cordis. There's another one, I think it was a couple years ago, it was a person that a hairspray bottle kind of exploded in her hands. And the hairspray bottle hit her in the chest with just enough force at just the wrong period of time that she went into cardiac arrest. Right? But again, a more common scenario seems to be around the kid with that's playing baseball, gets hit in the chest with a baseball, and they collapse. Right? And it was just that force being applied at just the wrong period of time. And again, on the upslope of the T wave. It's what on the ALS side in synchronized cardioversion in tachycardia, right, where we're trying to sync cardiovert, the synchronization is so that we avoid delivering that cardioversion on the upslope of the T wave. That's why we press that sync button. And so the monitor can pick up, so the monitor can avoid delivering that electricity here. And it delivers that electricity. Usually there's a little triangle or something will show up over top of the QRS complex as the monitor is starting to track QRS complexes so that it knows when to deliver that cardioversion so that we avoid hitting the heart with the electricity on the upslope of the T wave and avoid inducing commotio cordis ourselves. There we go. All right. So that's all I got on these for you. There's other ones too, right? I was making this slide and there's just so many different things. There's pulmonary contusions. Just like we have a cardiac contusion, there's pulmonary contusions. Just like if we have a cardiac contusion, the heart isn't going to be pumping well. it's not going to be able to do its job well because of that injured tissue. Well, the pulmonary contusions can be the exact same thing. The lung tissue is bruised, so that portion of lung tissue is not going to be able to do its job. So you're not going to be able to get good gas exchange through that injured lung tissue. There's traumatic asphyxia, right? There's diaphragmatic hernias, which is a little bit more abdominal, so I didn't really pull that one in here. But you see most of these, our treatment at least, is ABC shock management, fluid boluses. It's only in pneumothorax. If it's an open pneumo, we have an occlusive dressing. If it's closed and progresses to tension, we have needle decompression. But everything else we covered today was just ABC management, ventilation, shock management, fluid boluses. Right, so, which is what most students see. They like trauma because trauma looks a lot more straightforward. We don't have all these, 30 whatever different drugs that we're going to talk about. We say, okay, I got to stop the bleeding and maybe pain meds and rapid transport to the hospital. Right, so the trauma side is a lot more straightforward for students, and they feel a lot better because treatment is a lot easier. And treatment is way easier on the trauma side than it is on the medical side, where we have to kind of play detective a little bit more. Okay? So what that means is you're not just going to get 500 questions on how to treat trauma patients, because the treatment's all the same at a certain point. So it puts more pressure in your studying back onto how do you differentiate between a tension pneumo versus cardiac tamponade versus something else, right? So it really gets you into the anatomy and physiology a little bit more and making sure that you understand what's actually going on in the body and that you can actually identify what that patient's experiencing, right? So make sure when you're studying your trauma section, whether it's for class or National Registry or wherever you're at, when you're studying the trauma, don't just stop reading at the treatment level, because you're missing a whole aspect of it that's critically important. So you have to be able to identify what's going on with my patient. Even if it's two things where our treatment is going to be the same, it's still very important that we identify what's going on with our patient, because then we can anticipate the kind of trajectory that patient's going to go on, right? If we know what's going on with our patient, or if we're highly confident in our differential diagnosis of what's going on with the patient, we have a better way to anticipate the injury pattern and the progression of it, so that we know, hey, if my patient gets worse, here's probably some of the signs and symptoms that I'm going to see next, as opposed to, hey, if my patient gets worse, these other things might go on instead, because it's actually this other differential. So it just allows us to better anticipate it, both in timing, but then also in what is actually going to come up if our patient gets worse. So that's a little bit on the trauma, chest trauma section, at least. I can tell you just kind of anecdotally, I've seen, I know we use more questions on pneumos and cardiac tamponades than we do, cardiac contusions and some of the other stuff, right? So it's all important, but out of chest trauma, the pneumo, I'll say pneumo and hemothorax and the cardiac tamponade probably garner a little bit more of the attention, and should probably get a bit more of your study time too, if you're looking at just finite number of hours in the day and you got a lot to study. So we got to learn it all. We have to understand it all, but let's start with the big two of pneumothorax and cardiac tamponade. And then we'll add in hemothorax, cardiac contusion, pulmonary contusion, traumatic asphyxia, all the rest of them after that. Let's start with your big two is the kind of study tip that I have for you guys today on that. So that's everything for the chest trauma section. Well, not everything. Everything we're going to cover today on that. Thank you. And I hope that this section was helpful for you guys. And we'll keep doing more.